the vision of 2030 regarding disease prevention and control in Kingdom. So this online webinar on rabies was organized by Saudi CDC in collaboration with the General Directorate for Zoonotic and Vector-borne disease in Ministry of Health. First, we would like to welcome our speaker, Dr. Charles Robertish. Dr. Charles Robertish obtained his veterinary degree from University of Pennsylvania and his PhD in biological science from University of Wisconsin. He was a former chief of rabies section in CDC, and he will talk about a comprehensive review. He will talk about a comprehensive review about rabies. And then the second speaker is Dr. Muhammad Mubaarak from General Directorate of Zoonotic and Vector Disease in MOH. He will talk about rabies epidemiology in Saudi Arabia. The third speaker is Dr. Shamsudeen. Dr. Shamsudeen will talk about the One Health approach in Saudi Arabia about rabies disease. After that, we will open the discussion and we'll receive your question and any if you have any comment, and we will try to answer the most important question as we can. So now we will start our first lecture with Dr. Charles. So you can start, Dr. Charles. Hello, do you hear me?
Yes. Hello.
Yeah,
hello. Can you hear? Can you hear me?
Yeah, your sound is clear. You can start, Doctor.
Excellent. And I thank all of the organizers for their very kind invitation today to give an overview about rabies, its detection, and its management. My objectives today are to go ahead and introduce topics that should be familiar to all of us in regards to its etiology, pathogenesis. I'm going to review the historical basis for how we conduct laboratory-based surveillance. I'm going to describe the current World Health Organization recommendations for human rabies prophylaxis, and then I'll finish up with some challenges and opportunities, particularly that the COVID-19 outbreak has faced us as a field. And as our very kind moderator mentioned, we hope to be able to answer any questions of anything that I say that is unclear, or if any discussion points that come up that you'd like to discuss at the end of the talks today. So when we're talking about rabies, this particular disease is an acute progressive encephalomyelitis. It has the highest case fatality of any conventional infectious disease. Just about every major civilization has described a malady like rabies throughout history. In my mind, I believe that rabies is the major viral zoonosis, given its burden and its distribution and its cost. Nobody really knows how many people die of rabies every year because our surveillance systems globally are very poor. And so in a good year, we may only have 20,000 human fatalities. In a bad year, that may be over 100,000 deaths. In addition, a lot of the burden of rabies associated with the economics, aside from direct losses in animals, come from the tens of millions of humans who are exposed to rabies and require medical oversight, public health investigations, and post-exposure prophylaxis. Now, oftentimes, particularly today because of COVID, people may use the term eradication. Rabies is not a candidate for eradication. It's a disease of nature that perpetuates in pretty much all mammals are susceptible, but major mammalian reservoirs in carnivores and bats. So unlike smallpox and rinderpest, we're not really talking about eradication of rabies given the tools that we have available today. And with the exception of Antarctica, rabies is found on all inhabited continents, and with very rare exceptions, places may have either never reported the disease, such as in parts of Pacific Oceania, or have been able to control and eliminate the disease, at least in domestic animals. And it begs the question about wildlife. And despite all of these major issues in regards to rabies, it's not easily communicable. It's an infectious disease, but it really needs to gain access to the peripheral nervous system. And so by working at biosafety level 2 conditions, a box within a box within a box, figuratively, we can very safely and effectively conduct laboratory-based surveillance for this disease. In regards to etiology, when I was a child, we only knew about rabies virus. But about every decade since the 1950s, what were called rabies-related viruses were discovered, to the extent that they're now called Lissaviruses, the family Rhabdoviridae, that is rod-shaped viruses like vesicular stomatitis and a wide variety of other genera of rhabdoviruses. Lissaviruses belong all to one genus, and every lissavirus can cause rabies. We have more than 16 different lissaviruses that have been discovered. And the reason that we're concerned about these, as you can see on the slide, the ones in the green and red lines, is because some of the lissaviruses, we have no known human or animal biologics. And we hope that what are otherwise considered phenomenologies will not become tomorrow's emerging infectious diseases because we have no way to prevent them. In terms of typical virion morphology, this was a very excellent paper published recently from cryo-electron tomography, which shows the very nice bullet-shaped figure of a single rabies virus virion. These are about 1/10,000th of a millimeter. And you can see that RNA striations in the center of this virion. There's a membrane that binds the ribonucleoprotein on the inside to the outside. You can see those glycoprotein-like spikes marked in red. The matrix protein binds that inner nucleocapsid across the membrane to the outer glycoprotein. And there's also the nucleoprotein, which helps protect and encapsulate the RNA. And there's a phosphoprotein as well as a very large polymerase, RNA polymerase, that's necessary for viral replication. Two major antigens, that inner N designated in purple, nucleoprotein, forms most of what we used to regard as Negri bodies as far as inclusions. It's an internal protein. And that external protein not only is used to bind to receptors from the virion standpoint, but also forms the basis of all human and animal vaccines. In terms of basic pathobiology, almost all rabies cases are caused by a bite. Virions are deposited transdermally in the wound, primarily through a bite or through a scratch. For example, if there's virus-laden saliva on a claw, those virions gain access to the peripheral nervous system through a variety of receptors, and then move in a retrograde fashion from the periphery into the spinal cord with high neurotropism into the brain. Thereafter, almost all innervated organs are affected, in particular, the major portal of exit, the salivary glands, and the cycle repeats itself after a variable incubation period. Now, we only know enough information on the pathogenesis of 3 domestic species, dogs, cats, and ferrets, and we recognize in these 3 species, one, not only is viral excretion intermittent, but that we can also use the observation about the pathobiology of rabies to observe animals that are suspect, such that if a dog bites a person and is put under observation and remains normal for at least 10 days, then we know that that animal was not rabid, and that individual in a low risk situation does not require rabies prophylaxis. This is also an issue because animals that otherwise appear normal can still be excreting virus days before they become ill. And that's the reason for these 3 species, dogs, cats, and ferrets, that we not only have abundant laboratory investigation on their pathogenesis, but also epidemiological data, that these are the only 3 species that we can utilize this 10-day observation period once they're suspected in terms of an animal bite. Dogs are the major global reservoir and responsible for most human rabies cases, but we also recognize that cats are an animal that oftentimes are ignored or are not appreciated as much as other species. In fact, in places where canine rabies has been eliminated, cats often tend to be the major domestic animal that's found rabid. For example, in the United States, rabid cats outnumber cases of rabies in dogs. And as opposed to dogs and their relatives, such as canids, neither the domestic felids nor their wild relatives, they're very effective vectors, but none of them are known as reservoirs. And so all the cases of rabies that we find in domestic and wild cats around the world are all due to spillover from a major reservoir, such as a domestic dog that's rabid, or from a wildlife reservoir. All the cases of rabies in the world in cats are due to transmission from another animal. So this demonstrates that although all reservoirs of rabies are also vectors, not all vectors are reservoirs. And so we can talk about dog rabies, meaning these are viruses that are perpetuated in dogs, but we really can't talk about cat rabies. We can talk about cases of rabies in cats, but not cat rabies, because it's totally dependent upon another species. Diagnostics are really designed as a fit for purpose. And we've had huge progress over the past century in how we diagnose rabies in a suspect animal, or when conducting laboratory-based surveillance, or for the designation of rabies-free status. We've made huge progress since the early part of the 20th century in the dependence upon histology and Negri bodies, such that in the 1940s, the direct fluorescent antibody test became the gold standard for the demonstration of Lissavirus antigens in the brain of a suspect animal. Since that time, the direct rapid immunohistochemistry test has also become a recommended diagnostic test for both the WHO and the OIE. besides looking for rabies virus antigens, sometimes if individuals die in an untoward fashion by routine electron microscopy, the traditional bullet-shaped particles reminiscent of not only rhabdoviruses, but specifically lissaviruses may be observed in the brain tissue. So one can observe directly virions or the actual antigens of lissaviruses in the brain. These viruses have the ability to suppress the immune system, and in particular the innate immune system. And for that reason, animals with a progressive encephalomyelitis from rabies oftentimes do not mount a serological response until late in the disease. Individuals who have been vaccinated, you can't use serology there as an indicator because they'll already have pre-existing antibodies, both humans and other animals. But in the cerebrospinal fluid, you will find antibodies, oftentimes end stage, in affected hosts, regardless of vaccination status. Also, in the old days, we used to use animal inoculation, virus inoculation through intracerebral inoculation into things like mice, particularly suckling mice, but we moved to virus isolation in cell culture, such as murine neuroblastoma cells. And in particular, we've had the advent from the 1980s onwards of molecular techniques. First, the polymerase chain reaction and its antecedents to date. And there's been increasing utility, particularly in the 21st century, to move from central laboratory-based testing to decentralized testing, particularly with rapid tests such as linear flow assays. The one thing we need to be careful of, regardless of the diagnostic technique, is which specimen we're talking about and how it's handled. And so, for example, if we're talking about the direct fluorescent antibody test, we're talking about a full thickness cross section of the brainstem. And so in this slide, this is a cross section. All of those viral antigens in green in 3 dimensions are coming out of the screen, the slide at you, the same as wires from the periphery moving into the spinal cord and into the brain. And if you don't have a full thickness cross section of the brainstem, you cannot definitively say that that animal is negative. If you have other areas of the brain and it's positive, fine, the animal's diagnosed as positive. But if you don't have a full thickness cross section of the brainstem, you cannot definitively call that animal negative. This is a summary of the direct rapid immunohistochemistry test, or the DRIT. It's similar to the DFA in that it detects viral antigens in the brain. The difference is, instead of using fluorescence, we're using chromogens. Instead of using acetone in the DFA as a fixative, we're using that very excellent histological fixative formalin for a very brief period of time for biosafety. And in addition, besides formalin and chromogen, we're using light microscopy instead of fluorescent microscopy. All of these make the DRIT a more simplified, very rapid, in less than an hour, once you make your brain impression, method to help decentralize, not only in the laboratory, but you can actually do this in the field with a little bit of forethought, either having a battery for your microscope or using a mirror in old-fashioned methods using the sun. There's been a lot of attention of late, particularly in lesser developed countries, for these so-called lateral flow assays as a point of contact test, very similar to the methodology used, for example, instant prep tests for chemistries or for pregnancy tests, that within a relatively short period of time, matter of minutes, that you should be able to get these bands as the homogenized brain moves across this absorbent, binds to the antibody, and has a readout with a line. These are used most often in surveillance, laboratory-based surveillance in the field. For example, if one is looking at wild animal diagnostics, there is still some concern about using them because of the issues of false negatives. And as with any regulatory oversight for diagnostics, if one is interested in doing this and using this as a routine method for ruling out rabies in an animal that's exposed somebody, hopefully that there's some regulatory oversight and licensure of that test. From the 1980s into the present time, there's been the utilization of the optimization of molecular methods such as RT-PCR. We recognize there are a number of limitations with that first generation conventional PCR, a lot of which have been obviated through real-time PCR, to the extent that many centralized labs are now using the US CDC recommended LN34 pan-Lissa real-time RT-PCR that allows a readout of the diagnostic process very rapidly in typing using these colored oligoprobes with an intercalating dye to be able to visualize it as you're actually running the diagnostic. So there's been great strides, assuming that you have the sensitivity, specificity, as well as the necessary equipment, personnel, reagents, etc., to be able to perform this test. It's just a quick summary of the pathobiology superimposed upon the fit for purpose issues that we just discussed briefly in regards to diagnostics. We can give a week-long course in diagnostics. Sometimes we have day-long courses just in a single diagnostic technique. So I apologize in advance for having run through some of those major techniques that are reviewed and recommended by both OIE and the WHO. Just as we talked about rabies in cats and dogs and the issues about excretion, etc., we also recognize that if you have a person who's been bitten by a laboratory confirmed rabid animal, and within 4 to 6 weeks, that individual experiences progressive encephalomyelitis and the hallmarks pathognomically of aerophobia and hydrophobia, a clinical diagnostic suspicion is readily evident. However, we also have to recognize that clinical challenge where sometimes we don't have that furious centralized rabies, but rather an acute progressive, slowly progressing myelitis, ascending myelitis, particularly in vampire bat cases, and about 20% of some cases of dog rabies. And this sometimes can be missed, particularly if there's not a history of an animal bite, or because incubation periods can be long. Although they can be on average 4 to 6 weeks, in very severe cases, we know that within 7 to 10 days, the patient can be dead. But the longest known incubation period that's been documented is in excess of 8 years. So when you have these longer incubation periods, or oftentimes when you have prophylaxis that's not full, it may be incomplete, vaccine only, we oftentimes can have these ascending paralytic rabies that still maintains consciousness and can have some prolonged incubation periods, even though they tend to be fatal as well. And it could be some immune-mediated processes that help explain one of the reasons why some patients experience paralytic as opposed to furious rabies. So recognizing the basis of diagnostics for antigens, antibodies, and amplicons, recognizing what we understand about the pathobiology of rabies, we can perform antemortem diagnostics in the human patient, and rabies should be on the differential list whenever a viral encephalitis is considered. Oftentimes, rabies winds up on that differential as a default because all the more common reasons for that presenting encephalitis are ruled out. Why do we do antemortem diagnostics? 1, to be able to arrive at a definitive diagnosis. 2, to provide closure for the patient, for the family. 3, to go ahead and ensure that we've got proper PPE in all of our healthcare people. 4, because of the individuals who also could have been exposed to that same source. And so to be able to institute a proper public health investigation. And of course, if we do this dutifully, to be able to rule out rabies and still look for other potentially treatable maladies if we can definitively rule out rabies. So recognizing that late in the course, that'll be by the time the patient presents, we can look for antibodies in the serum, both to that inner nucleoprotein as well as virus neutralizing antibodies, as well as in the CSF, regardless of a vaccination status. In addition, we can look for viral antigens if we do a temporal lobe brain biopsy through the DFA, or full thickness skin biopsy through the nape of the neck, or we can use saliva either for virus isolation or for amplification. So these are the major sources and the major tests, the major things that we're looking for ante-mortem diagnostics to be able to come up with a definitive diagnosis. This is just one quick slide demonstrating the nuchal skin biopsy that's done at the nape of the neck, ensuring that it's from an area that's been shaved with many hair follicles. The utility of this is because it can provide you an answer in an hour or two. One, because you can look directly for viral antigens associated with those follicular neurons in that cross section that you can see in the center. This isn't surgery. This is a full thickness skin biopsy, a punch biopsy. Some of that material can go off for a real-time PCR. The other material can be mounted on a cryostat and cut and then looked at by fluorescent microscopy. Besides transdermal exposures, excuse me, or rarely mucosal, if an individual dies acutely, for example, hit by car, traumatic injury, and they happen to be incubating a zoonotic disease like rabies, and their tissues or organs are transplanted, we can also have transplantation associated rabies, which has been reported not only in North America, but also in the Middle East and in Asia as well. So we have had these very rare cases of transplantation associated rabies from patients who have been affected, but they weren't known to be affected at the time transplantation was performed. You can see that wide variety of, in red, antigens that were found in a variety of the associated organs that are transplanted, typically be it lungs, liver, heart, etc., corneas. This is a very quick reminder, particularly for animals, as to why do we focus upon the brainstem. That is because not only do we have the projections of major facial nerves, such as the cranial nerve, such as the facial nerve, the trigeminal ganglion into the brainstem, all the innervation for the salivary glands originates from the brainstem, and everything caudal to the brain, from the hind limbs, the forelimbs, the tail, etc., passing caudally, cranially, all has to go through the spinal cord, through the brainstem. That's the reason that if you don't have a full thickness cross section of the brainstem, you could miss a rabies case because of its innervation and because of its applied anatomy, as seen in those graphs. Now, we talked about the taxonomy of Lissaviruses. This one very nice summary slide from our colleagues at the Pasteur Institute demonstrates the wide variety of rabies viruses that we have around the globe. Most of these are in canids, such as dogs, wolves, foxes, raccoon dogs, jackals, coyotes, etc. But they're also found in mongoose. They're also found in skunks. They're also found in raccoon dogs and in raccoons. And then, of course, superimposed upon all of those, we have abundant rabies viruses in bats. We only have rabies virus in bats in the New World, even though we have other Lissaviruses in other bats in the rest of the world. So we can use these differentiations antigenically and genetically, not only for epidemiological studies, but also when you have a case in an animal or in a human without a history of a bite, we can then go ahead and identify the lineage of the virus and help to understand how that exposure may have occurred. We recognize that animal bites are very common, particularly dog bites, into the millions around the world. And in the Mediterranean basin in the Middle East, that's no exception. We can see a wide variety, sometimes in excess of 200 to 500 people per 100,000 are bitten. So animal bites are a big issue. And that's one of the reasons why, not only for World Rabies Day in this session today, that we're concerned about animal bite prevention and follow up, of course, with rabies prophylaxis if needed. We also recognize that this portion of the Middle East and the peninsula is manifested in a wide variety of different variants. The superimposition of not only historical, classical canine rabies, you can see they're coming in from the west from Turkey, as well as Asian dog viruses coming in from the east, from the Indo-Pakistani subcontinent. And then superimposed upon all of that, we have wildlife rabies. We have Arctic-like viruses in our free-ranging wildlife, as well as particularly foxes. And sometimes you'll have superimposition of both domestic animal as well as wildlife rabies that helps complicate this epidemiology. And if you understand the epidemiology, it helps to simplify the management as utilized in this particular cartoon. That is, if you have primarily canine rabies, then focusing upon canine rabies elimination is the major issue, as you can see, as it is throughout major parts of the region, as opposed to is wildlife rabies operative, such as in foxes in the area, that helps to complicate the situation. And besides the reservoirs, that is foxes and dogs, we recognize that all mammals are susceptible, and in particular, there are some species that may be found to be reported. And so at one time, when they were abundant, wolves as a good canid may have been a reservoir. Now, primarily, they're a vector from spillover from dog rabies cases. And similarly, we already mentioned spillover into cats, both wild and domestic. Potentially non-human primates such as baboons may be infected by interactions with dogs or from wildlife cases. All of our domestic animals, particularly from interactions with dogs as well as free-ranging wildlife. And sometimes we get unusual cases such as in the hyrax can also be found as indicators. These are all indicators primarily of spillover infection from some reservoir, either the dog or a wild carnivore. We also have to recognize, at least in the new world, that bat rabies viruses are operative, and in the old world, bat lissaviruses are operative. That is, lissaviruses, with the exception of rabies virus, that can not only maintain the infection bat to bat to bat, but can spill over into carnivores. Many carnivores, domestic and wild, like to eat bats, as well as in humans, because oftentimes people are curious, children in particular, and may pick up a bat, or people may have a bat in their house and not recognize that they were exposed if, for example, they were asleep and a bat fell on them and bit them. We don't know very much about lissaviruses in the Middle East, primarily because the issue has been canine rabies as well as wild animal rabies, such as foxes. This collective map demonstrates the range of some of the bat hosts that are known reservoirs for lissaviruses in other parts of the world. And we also recognize that the ways that you would do surveillance for wildlife is a little bit different than you would do it in carnivores such as dogs or foxes. That is, very few bats are found rabid. These free-ranging animals are highly beneficial, and so you would have to have very biased surveillance, and serological analyses are often very useful to demonstrate, one, that species A is found affected, that then allows your public health communications and laboratory-based surveillance to be fine-tuned. Certainly not the random routine killing of healthy animals, which is not only unethical, it's against ecological principles, but it's certainly not supported by economics or other means. So we talked about canine rabies superimposed with wildlife rabies in a very dynamic part of the region. And this is one country where Aberdeen has demonstrated that wildlife rabies is involved. For example, if you go ahead and look at the numbers of cases that they've had from foxes versus dogs, etc., that 70% of those rabid animals tended to be foxes as far as percent positivity. So there are parts of the Arabian Peninsula and the parts of the Middle East for which we know that wild foxes will be the primary reservoir. In addition, since we know that wildlife can be important epidemiologically in this part of Oman, it's not surprising that when we go ahead and look at the human cases that have been recorded, most of the cases have been recorded after wild rather than dog exposures. And in addition, these surveillance cases, these case series demonstrate the relatively high case fatalities when we've had exposure to highly innervated areas, particularly in the face and head. This is one of the reasons of concern after wolf bites, because bites from wolves have some of the highest case fatalities in rabies because of the way that these apex predators tend to bite deeply and multiply and severely about the face and head. In addition, even in places where we don't think there is much rabies, we can still have a transboundary or imported cases, as was demonstrated in this recent study from Qatar. That is that some patients that were exposed in Nepal were then diagnosed with rabies, and from differentiating the samples that are normally found either in their wild animals or domestic species, it was demonstrated that they were able to base these lineages with the common viruses that are found in the Indian subcontinent rather than in the Middle East region. So we've talked about etiology, pathobiology, diagnostics. I'm going to turn next to a summary of the current World Health Organization positions on immunization. And the reason that this was reinvigorated was because there's been some major technical advances as well as improvements to the safety and efficacy of current human biologics. There was a 2017 SAGE recommendations to WHO that helped review the evidence for these, and then the publications of the WHO thereafter in 2018 that I'll summarize based upon the very kind information that's been supplied to me by my colleague, Dr. Bernadette Abelritter from WHO Geneva. What the updates focused upon was, again, the definition of the exposure categories, the demonstration of the advocacy for the intradermal route as opposed to the intramuscular as a dose savings means, more expedited post-exposure as well as pre-exposure schedules, the more prudent focus use of rabies immune globulin and not just classical polyclonal but also monoclonals, and how to prioritize and do risk assessments on patients that are so exposed, particularly in times when we may have a limitation in supply of these. Now, although it's not recommended to be touching animals, simply seeing or petting an animal, being in the room with a rabid animal, does not constitute exposure. Lissaviruses do not penetrate intact skin. We have to have either transdermal, that is a scratch or a bite, or mucosal before we're talking about these categories of exposures. Category 2 would be a nibbling without significant abrasion. Category 3 would be a full transdermal or a mucosal. In the United States, we don't have a differentiation between category 2 and 3. We regard all exposures both 2 and 3 combined into 1, because we want to assume zero risk for that exposed patients in individuals when we don't have any limitations in supply. When that patient presents, either at an emergency room or at a clinic, or at their primary physician, one goes through a risk assessment. What kind of an exposure was it? Was it a bite or was it a non-bite? What kind of animal? We're not talking about a fish bite, a shark bite, a snake bite. We're talking about a mammalian bite or not. Almost all cases are caused by a bite. Is the animal a dog, cat, or a ferret? And can it be observed? Is the risk relatively low, such as was the person's own vaccinated, healthy, provoked bite exposure? There wouldn't be any need for prophylaxis in that situation, as opposed to an unprovoked bite from an ill animal, very severe around the face and head, particularly if we know that there's a canine rabies outbreak going on, and that would constitute a need for prophylaxis right away. Prophylaxis is always indicated when you suspect rabies to a high degree. Now, we have quite a few rodent bites throughout the world, particularly house mice and rats. These are very common, and yet there are no known rodent reservoirs. There are no documented cases of transmission from rodents to humans. We can't find a specific variant or lineage associated with rodents. And so, unless except in very unusual circumstances, unprovoked severe bite from an animal that's available and that is ill and is able to be submitted to the diagnostic laboratory, prophylaxis is almost never indicated after routine rodent bite. The local epidemiology is also going to be critical. So, for example, in some of our Pacific islands like Hawaii, prophylaxis wouldn't be indicated after even an unprovoked animal bite because surveillance has demonstrated that there is no rabies. It's our only rabies-free state. So the epidemiology will be informing as to what kind of animal and what one needs to be concerned about. What about the immunization history? Although no vaccines are 100% efficacious, having a history of vaccination documented in an animal lessens the relative risk that that animal is rabid. It doesn't say it can't be, it just lessens the relative risk. What about the prior vaccination of that individual? And in addition, don't forget that that person could have been exposed abroad. For example, we had a physician here in the US who did not have pre-exposure. They went to India. They were bitten by a dog there. They did not receive post-exposure prophylaxis there. They came back. They did not receive PEP when they returned, and they died of Indian dog rabies. So a history of foreign travel also needs to be taken into account because the epidemiology of the situation is going to be different at home versus abroad. As you would with any animal bite, thorough washing, wound cleansing for at least 15 minutes with soap and water. It always involves that. In fact, we know that by thorough washing with soap and water greatly decreases the relative risk of rabies acquisition. And then depending upon the exposure, for example, category 3 in the WHO definition of exposure, it may also involve rabies immune globulins. This is the recommended post-exposure prophylaxis realm for naive individuals, that is, individuals who have not been previously vaccinated. So recall when it was back with nerve tissue-based vaccines, that it was 14 to 21 daily doses intracutaneously. That no longer occurs, thankfully. When cell culture vaccines came on board in the 1970s, we had 6 doses, so from 14 to 6. Thereafter, we went down to 5 traditional doses intramuscularly. When we had our limitation in supply around 2009 in the United States, both based upon the epidemiological, the pathobiological, the immunological, as well as the serological responses in patients, we saw that that fifth dose did nothing. That is, we had peak antibodies occurring at day 14. Therefore, that fifth dose is obviated. The same as we don't do 14 doses or 6 doses. 5 doses are no longer recommended by WHO, and even the United States, we don't do 5 doses anymore. It is not supported on the basis of the evidence and is costly, and we also don't have great compliance by our patients. We also recognize that we can have shortened 1-week intradermal schedules on days 0, 3, and 7, with using 2 intradermal doses at that time. This is very cost effective in very high volume clinics. So for example, if hundreds of patients are coming in, intradermal is very cost savings. And any patients who come in later in that day, maintaining the cold chain for that day, can also be utilized very effectively for post-exposure prophylaxis. That way it increases the overall accessibility in the community for post-exposure prophylaxis. For individuals that were previously vaccinated, they would get a booster dose. That is, if they've either had pre-exposure traditionally of the 3 doses or at least 2 doses previously, there's no rabies immune globulin recommended because the individuals are assumed to have antibodies on board, or if they're immunocompetent and they were vaccinated with one of the recommended biologics, a potent anamnestic response will occur. Why do we go ahead and utilize RIG or rabies immune globulin, either polyclonal or monoclonal? It's because it provides a bridge between day 0 of exposure and when antibodies are elicited actively by a vaccine. So it is a very important component that helps to neutralize viruses, particularly peripherally in that wound, before the advent of the patient's own virus neutralizing antibodies. At a minimum, RIG is used for category 3 exposures. It's only given once. If for some reason you don't have RIG and you've used vaccine, RIG's not indicated beyond day 7 because the patient is making their own antibody. Importantly, RIG is infiltrated into and around the wound. For homologous products, human rabies immune globulin, the maximum dose is 20 IU per kilo. And for heterologous products, the maximum dose is 40 IU per kilo. In the old days, they used to do skin testing. That was for horse serum. There is no need for skin testing from equine rabies immune globulin utilization because it's not reliable. We have had cases where individuals were given the vaccine only without RIG. There have been human cases after exposure where the RIG was not infiltrated. And of course, if a patient shows very delayed, that is, comes in a month after severe exposure already exhibiting clinical signs, then it's very much unreliable that PEP is going to be utilized. PEP is going to be indicated in all cases with a definitive history of exposure within reason, as long as that patient is not demonstrating clinical signs. And in the old days, based upon mass, not only were all wounds infiltrated, but any remainder was infiltrated intramuscularly. Again, the same as with ID. Dose savings, the primary focus is the proper and thorough infiltration of RIG so that other individuals may be able to be utilized in a triage fashion. If you only have a certain amount of RIG in a given location, then you're going to do multiple and severe bite wounds, particularly to the head or those with a known immunocompromise. We also recognize that bites by bats, because they can be small, oftentimes those lesions may be ignored compared to more severe lesions or lacerations caused by carnivores. Everybody who's at risk of exposure occupationally should receive pre-exposure vaccination. That includes laboratory workers, diagnosticians, vaccine producers, veterinarians, veterinary staff, animal control officers, wildlife researchers, etc. Anyone who's occupationally exposed should have pre-exposure on board, and there are some indications if human exposure incidence is high, very rarely, that certain populations should receive pre-exposure vaccination as well. It's also been simplified. It used to incur 3 doses on days 0, 7, and 21 or 28, now to 1 site on days 0 and 7 IM, or a 2-site ID also on days 0 and 7. That is a primary and a booster. We encourage a greater enhancement of communities at risk. If they're out there handling animals, vaccinating dogs, etc., they should have pre-exposure vaccination. And intradermal immunization is a very cost-effective way to do that. This summarizes everything that we've gone over. Pre-exposure for those at risk, wound care for any animal bites, rig and vaccine for naive patient, vaccine only for individuals who've been previously vaccinated. And this summarizes the prior recommendations by WHO by having longer duration, now shortened with the newer recommendations, the demonstration of the cost-effective dose-sparing intradermal savings that are demonstrable, the shortening of the pre-exposure schedules from 3 to 1, the focus upon the infiltration of rabies immune globulin as opposed to the need for a distant intramuscular dose administration, and the allocation of rig focusing triage fashion on all category 3 exposures, high category 3 exposures. This also helps summarize all the things we talked about in terms of the applied pathobiology in regards to post-exposure prophylaxis. That is, you have a very narrow prophylaxis window while that virus is in the periphery and slowly moving towards the central nervous system for wound care, infiltration of rig, and the induction of multiple doses of vaccine, as opposed to the onset after variable incubation period if prophylaxis is not indicated or demonstrated. Putting all of this together, although we focus primarily upon human prophylaxis after animal exposure, we recognize in a One Health capacity that we're really talking about not responsive only to the exposed patient, but more importantly at the reservoirs and in the situation in regards to canine rabies control. And it's really been this technical revolution post-Pasteur over the last century that allows our ability not only to focus upon pure, potent, safe, and efficacious biologicals for humans, but also for animals, as well as rabies immune globulins. And it's also been our technical advances in laboratory-based diagnostics, molecular tests, being able to differentiate the agents, wild-type street viruses, but also the ability to go ahead and improve the biologics for human and animal rabies immunization, particularly post-World War II, unto the present time, such that we're way beyond first-generation nerve tissue-based vaccines into third-generation recombinant biologics that can be used very safely without any indication of the possibility of rabies. All developed countries have eliminated canine rabies transmission. And this nice graph illustrates that if you can eliminate canine rabies transmission by mass dog vaccination, not through population reduction, that human rabies cases will fall. It also allows you the epidemiological luxury when you don't have hundreds or thousands of cases from dogs to focus upon wildlife rabies and to be able to manage the situation accordingly. And this has been a pattern reported and repeated not only in developed countries, but also increasingly in developing countries. There was a very nice paper very recently by our colleagues at CDC that demonstrate that you can either have central point vaccination for your mass vaccinations, that is, have the people come to you at central places that you know are logistically suitable, or in terms of free ranging animals, very expensive, putting out animal control officers vaccinated to go ahead and safely net and vaccinate those free ranging animals. It also brings up the topic, given what we've mentioned about 21st century biologics, for the consideration of oral vaccination for the cost savings of not having to run after all of those free ranging dogs, but rather to be able to distribute and have those dogs eat in your presence a vaccine laden bait to achieve the same goal, except much less expensively. And we know that over the last 40 plus years that we very safely and effectively have been able to utilize a wide variety of viruses, not only second generation attenuated rabies viruses, but also now third generation adeno, pox, and rabies virus for as both vectors as well as gene coding devices very safely and effectively that have been used for the control and local elimination of rabies, for example, in Western Europe, increasingly in parts of North America, Canada, and the United States, as well as in South Korea for wildlife rabies prevention and control. This also demonstrates two things. Not only these are real time, they're going on as we speak. Just to my state to the west of us, we have the distribution of vaccine laden baits in Alabama right now. But the only way, besides biased passive public health surveillance, that we can find out what's going on is to have decentralized, focused surveillance, as you can see in that map in southern Canada, in Ontario, that demonstrates the surveillance effort. All of the green demonstrates their surveillance efforts. The little blue indicators where cases are based upon that decentralized through DRIT surveillance, and some of those red are in foxes. So blue are raccoons, red are rabid foxes, and green demonstrate your surveillance effort. Now, demonstrating that decentralized surveillance is the way to go. For example, in a country like the United States, and zoonotic for rabies, you can imagine our limitations if we only had centralized diagnosis at the CDC in Atlanta. Rather, we have decentralized surveillance. We have more than 100 diagnostic laboratories dispersed throughout the United States. Some states have more diagnostic facilities than most countries. It's the way to go as opposed to centralized, capital driven. You need to go to demonstrate laboratory based surveillance in those affected communities. One of the controversial things in the future will be, do we want to go from the distribution of vaccine laden baits and have a one up, that is, one animal eats one bait and gets vaccinated, as opposed to will we have fourth generation safe and effective vaccines that are transmissible, such that, for example, if we're thinking about what do we do about vampire bats, do we want to be able to coat them with a transmissible vaccine and through grooming have that vaccine spread animal to animal? We're not there yet. It's just a very interesting concept that, based upon modeling, demonstrates that you'll get much more bang for your buck than from the way that we're doing oral vaccination at the current time. Another opportunity and a challenge is that we know that there is no proven cure. There are no licensed drugs. We've had some insights, post-exposure failures, of patients who were exposed, given PEP, for one reason or another. They got excellent medical care and they survived. Then in 2004, we had Gina Giese in the Guinness Book of World Records. She was our first patient who survived rabies without a history of prior vaccination and the advent of the so-called Milwaukee Protocol. We've had relatively few patients who've been able to survive from the Milwaukee Protocol and its various additions, what this demonstrates is that there are many, many more things that we need to find out about the pathobiology of rabies, as well as we have no antiviral drugs. So we're hoping to land on the coattails of not only concerns about filoviruses, such as Ebola or Marburg, which are also negative stranded RNA viruses, and now particularly another viral outbreak with COVID, what we may learn about antiviral drugs from other agents and utilize these in a biased way for rabies, and focused upon what we're understanding about the individual genes and proteins in the viral life cycle, so that perhaps someday we'll have some antiviral drugs effectively in our arsenal for rabies prophylaxis. Remember at the beginning of the talk, we also brought up the issue of what do we do about rabies lyssaviruses that we have no vaccines for? Next generation chimeric vaccines that we may incorporate multiple genes and multiple antigens from some of these genetically diverse lyssaviruses if the need calls for it. And all this focuses back to the primary theme for World Rabies Day, the 0 by 30. The GERD, the global elimination of human rabies caused by dogs, mass vaccination of dogs, prophylaxis of individuals who are bitten by suspect animals, and the indication based upon your focused, purpose-built, laboratory-based surveillance, if wildlife are there, do we need to also entail vaccination of wildlife because of spillover and maintenance, particularly of wild canids, such as jackals, etc. So in this very brief talk, it's been my pleasure to share some of my thoughts with you. Canine rabies is the major issue throughout the world. However, we can do something about it. All developed countries have eliminated canine rabies transmission, increasingly using the area in the Americas, and Rabies in the Americas conference is coming up at the end of this month, just a plug, that the Americas is the regional model that even developing countries can eliminate canine rabies using the STEP model. That prompt and proper human prophylaxis virtually assures survival after a risk assessment when someone is bitten or otherwise exposed. That although all mammals are susceptible, we're most concerned about the domestic dog and wild canids, such as foxes, jackals, etc., and superimposed upon them either bat rabies viruses or bat lyssaviruses. That besides mass dog vaccination, we know that we can manage wildlife very effectively through oral vaccines, and this tool may also be useful for managing canine rabies where indicated. Pathogen discovery will continue to find new lyssaviruses that are out there, as well as making perhaps lyssavirus as opposed to rabies virus-based vaccines sometimes in the near future. And of course, the bottom line is a One Health approach. It's not just human health, it's not just animal health or environmental health. It's the superimposition of all these transdisciplinary expertise that's going to move towards the 2030 rabies elimination. And certainly there are challenges that are out there and other opportunities, issues about climate change and how that's going to impact the demographics of people and animals, the emergence of new viruses and the need for new biologics. And as wildlife continue to emerge as major lyssavirus hosts, the way that we conduct surveillance will also change in time, because these are very dynamic zoonotic agents that really bear our curiosity and focus. And I think with that, I thank you for your time, and I turn it back to our very kind hosts.
Thank you, Dr. Charles, for your interesting and informative lecture, which was about the comprehensive overview about rabies disease. Now, we will open a question. Anyone have a question about the lecture? Or maybe we can make it at the end of the webinar. So we will move now to the next lecture with Dr. Shamsudeen. He will talk about rabies disease and One Health approach. So you can start, Dr. Shamsudeen. Dr. Shams, do you hear me? Yeah, you can start. Okay, well. Dr. Shams, your sound is not.
Hear me now?
Yeah, now it's clear. Yeah, okay.
Can you see my slides?
Yeah, the slide is shown up.
Okay, good. All right.
Okay, you can start.
Okay, good. Welcome everyone, and I do apologize to those who have tried somewhat unsuccessfully to get in through Zoom. I've been behind the scenes working with my colleague in the IT to see what can be done. It's been recorded on YouTube and will be available after the session. And those who also are watching from YouTube to be acknowledged as they attended the webinar. I will try as much as possible to go over some of, not to repeat some of the slides that have been shown by Charles. One Health, like in the last few slides which Charles talked about, the One Health approach is really the way to go about it. And just some basics, it's a collaborative effort, multisectoral and transdisciplinary approach, meaning that we don't concentrate basically on the Ministry of Health alone separately, or the Ministry of Agric, MIWA separately. We have to look at it as a joint effort in terms of the various government and non-governmental sectors that are involved in taking care of animal, human, and environmental health. So they work at the local, regional, national, and global levels with intention to achieve ultimate health outcomes. Recognizes the interconnection between people, animals, plants, and their shared environment. It's very important to mention plants. We often leave them out in the One Health discussion. The Saudi CDC is mandated by Ministerial Council decree to monitor communicable and non-communicable diseases and protect and promote health across Saudi Arabia. And so most of these mandates, when broken down, they are really under the One Health platform. And these are some of the points in the mandate ministerial decree that established the Saudi CDC. Health emergency preparedness, communication, and public health outcomes, and stakeholder engagement. Stakeholder engagement also involves non-governmental entities, which will see some of our collaboration with non-governmental entities. This is something that is expected if we are to implement the One Health approach. Research. Some of these slides have been mentioned by Charles, so I would not dwell on it. But he mentioned one point which we should understand is that this all warm-blooded animals are affected, FEDIAT, as we call it, and this will affect how we manage animal bites that come to the ER. If somebody is bitten, for example, by ostrich, we have seen this in surveillance. What is the way to approach it? Also, rodents, we have to give them vaccines based on rodents are FEDIAT, they're mammals, but we do not have any reports of rabies from these animals all over the years, as Charles reminded us. And now these are some of the animals that can be involved, that are involved in rabies epidemiology. Like Charles said, bats, they're the main reservoirs of Lissaviruses and also other Lissaviruses, which do cause rabies. And dogs also are reservoirs, like he mentioned. Now, a lot of these animals, the other animals are mainly end hosts. Some of the animals are of interest here. The fox and also the folklore here. This animal on the lower end of the screen is the honey badger. It's well documented for rabies transmission from the wild. We have it here all over Saudi Arabia, except in the Najd area, and it's very common in Jizan area. And the folklore is that it normally bites a dog, and 2 weeks after the dog will come down with rabies. It's called Gharir al-Asl bil Arabi. And we have camels and cats and sheep. But these animals basically are end hosts, just like we humans. And another animal to be worried about here in Saudi is the mongoose, again in Jizan. And because we do have high level of uncontrolled stray cats, we should be worried about this. If there's transmission from normal foxes to cats where they fight, they do have contacts where they fight over food. It can get transferred from cats. And we have had in the past, especially when we had a lab situated in Qasim, functional animal lab in Qasim, we've had for about 3 years, we had more cats being positive than dogs. And so this has to be emphasized because the love of cats in the country is enormous. And the risk has to be made known, and that cats can also transmit not just by bites, also by their licks and also by their scratches, which is very, very common for people to adopt cats here and take them from the street. We need to be aware of this. Charles has done a good job in this area. And I think I also talked about that. The CFR is 100%. So this is why we have to be worried about rabies. So once the person develops the clinical signs, I'm talking about humans, once they develop clinical signs, it's almost confirmed virtually 100%. That's why it's very, very important that we seek. This talk is something to be practical, that we seek medical care immediately. And the good thing here in Saudi Arabia, the vaccines are available in the ER, and they're available free of charge to everybody, Saudis and non-Saudis, at no charge, including the rabies immunoglobulin. So we need to, we don't pray we have bitten by a suspected rabid animal, but we need to know that it is available and it should be sought as soon as possible. Transmission to man, said bites, licks, trachees, transplantation, post-mortem procedures. Veterinarians are at risk here, aerosols from bat-infested caves. Though we have had 2 rabies outbreaks in the country due to transplantation, 2015 and 2018 and 19. So that's why one of the important issues here is to raise awareness amongst clinicians, and we have a high index of a suspicion. The last case of transplantation we had, it was quite clear the person who died and donor, cadaveric donor of 2 kidneys. It was very clear that he had viral encephalitis. It was not identified, but the clinicians said they did not know we had rabies in Saudi Arabia, even though they've been practicing for quite a long time. So I'm emphasizing on this because it is avoidable and the knowledge is there. The 2 people that received the kidneys died about 11 months after. Yeah, so it involves almost all of these organs here. I think Charles has spoken on the pathogenesis of the rabies virus, and it is ifraz fil lu'ab. It is which is excreted a lot in the saliva. And this is very, very important. It's extremely important, the excretion from saliva in terms of getting diagnostics here in Saudi Arabia. It is the easiest form of sample to take. We do know that there are a lot of resistance in taking brain material post-mortem. So we need to take as many ante-mortem samples as possible. One of them is the saliva that is excreted, but we do have to take it intermittently. And also, like Charles demonstrated, we should take samples from the nape, the skin at the nape of the neck of the neck. Yes, these phases, I think Charles did mention some of them. You mentioned about the encephalitic stages and the paralytic stages. And the paralytic stages are the ones that we may be missed in the clinic. And some of it may be related to bat rabies. And if we do miss it, again, because we don't do, we most often than not, the family of those who die of rabies, suspected rabies, do not often allow post-mortem. So the clinicians have to be aware of this and try to take as much ante-mortem samples as possible. I think Charles mentioned some of this. This is very, very common, but it's not. Sometimes this may be missed, but their preservation is very common. And this is paralytic rabies, and we do have a very strong acute flaccid paralysis surveillance in the kingdom, and Guillain-Barré syndrome is one of those presentations that the clinicians are very much aware of. But again, paralytic rabies may be mistaken for GBS. Again, these are some of the differential diagnoses we need to consider. Dengue is endemic in some parts of the kingdom and can be imported in the other parts of the kingdom. So, but variably, the kingdom is endemic. Also, West Nile virus we do have in the country, and Herpes simplex is known to occur. So the clinicians need to have a broad-based index of suspicion, ruling out some of these viruses and trying to take these samples, even when we do not have evidence of animal bites. Before, we've had one of the cases in which there was no animal bites, but the lady died eventually of classical signs of rabies and was positive by PCR. One of the things about One Health is moving it from the talk phase into the walking phase. We need to be able to walk the talk, and this is this is the basis of the End Rabies campaign 2030. Vaccinate, collaborate, and to be able to demonstrate that we're actually out of we have eliminated. We have to have baseline data. That is, we need to have diagnostic facilities available, and so we can do a comparison of data from year to year to show that at least we have reduced, if not completely eliminated, dog-mediated dog-mediated rabies. One of the things that is often asked is that do we have stories of success? Yes, we do, and this is one of the case studies I would just like to quickly present. Again, this shows that when everyone is aware and working together, and we have rapid communication, we can work to actually prevent fatalities from suspected and actually confirmed cases of rabies. So this happened in Qasim. The Qasim, I do know from past that they had very strong rabies surveillance system, and they didn't have one of the only two labs we have from the Ministry of Agri that was functional in terms of rabies diagnostics. It was at that time it was located in Buraida, the capital of the Qasim region, and A Saudi man was about 55 years of age, was in his farm and had an unprovoked attack by a wild cat. I repeat, a wild cat. This is not a stray cat, it's not a feral cat, it's a wild cat, which we do have as part of the mammalian fauna in Saudi Arabia, which again raises a lot of questions, like Charles was mentioning. The cat is most unlikely to be a reservoir, so it must have spilled over to the cat. And so the question maybe spilled over from a fox. Foxes are well known to have rabies in Qasim region and other parts of Qasim like Taif and Jove. So it's definitely a spillover to the cat. It could be from, we don't know if it's a bat, because we never got to be able to test it was positive, but we couldn't do molecular epidemiological studies. The interesting thing is that about awareness, this gentleman presented within 1 hour at the PHC in Uyun, Jawa, and that really afforded him to be able to get the staff were aware of the guidelines from the MOH, and they put everything into practice. Rigorous washing of his multiple category 3 wounds, face, hand, and thigh with flowing water. And they used the equine rabies immunoglobulin 40 IU per body weight, and to irrigate the wound sites. And they started him on the first dose of the 5-dose IM anti-rabies vaccines, which we still use in Saudi Arabia. In the US, I think Charles mentioned it, it's 4. And the new regimes by the surge of WHO also recommends 4, and other shorter doses by intradermal route. Now, because the staff of the PHC were really proactive, they got the wild cat captured. We don't often get this done. And its head was sent to the lab, which was 2 hours drive away in Boreda. This is very important because I think it happened if I'm correct, this happened in summer. And if the lab is really far away, the head may get to the lab and be actually rejected if it does not reach the lab in a good state. So the lab test, the cat's brain was tested positive using the gold standard direct fluorescent antibody. And this is where rapid communication comes in. This information was immediately given to the Moderator in Boreda and set down directly to the PHC in Uyun, Jawa. And they were so much on the alert that they informed me that if he refused to complete the dose, they will have actually asked the police to go and bring him from his house. And the gentleman survived. And I asked about him about few weeks ago, and he's still alive. He survived the COVID-19, alhamdulillah. And so this goes to show that the vet lab played a major role here, but the sad thing now is that lab has been shut down for a while, and so we may not be able to get the same diagnostics data about rabies occurrence in the mammalian fauna in Qasim, and the lab also used to take care of other areas from Saudi. So we have only one lab left, if my information is correct, in Hofuf that is functional for animal diagnostics. And like Charles did emphasize, we need to decentralize a diagnosis both at the human and the animal level. Jizan is highly endemic for rabies, but we do not have, and it's far away from Boreda, it's far away from Riyadh, it's far away from Hofuf, where we have the only functional lab. And so we do know that the mongoose there could be rabid. We do know that we have Gharir al-Asil, like I showed in that area up to Taif. And we do have human cases of rabies. What we do not have decentralized testing there. So we may not get the true picture of rabies in these areas. It's also good to look at where we had failures and learn from these and make changes. This was in the south of Saudi Arabia. This gentleman was in his house. Sorry about that. This gentleman was in his house and he was attacked by his own dog on likely unvaccinated. And it was a horrible attack. He lost 3 of his teeth instantly. He presented to the ER. He was not given a RIG for reasons unknown, but it was available when we asked. It was available in the protocol. He was given anti-rabies vaccines, and he moved away from there. He moved to another part of the country where he developed rabies, clinical rabies. But this was after I completed 2 or 3 of the 5-dose regime, and after a short stay in the ICU, he died, I think, of respiratory failure. And again, this is awareness. Saliva was not taken, skin biopsy of his neck was not taken, and they had the lumbar tap, and the CSF was available. Again, we had no local diagnostics in the hospital. It was sent abroad. It took some time for results to come back. Unfortunately, again, abroad, they didn't test the CSF or PCR. They did test only for IgM. It was positive for IgM, but again, we cannot say that this IgM was from an infection. It could have been from the vaccines that he received. The dog was killed and was not tested, and was unvaccinated. It was obtained from unknown, so unverified sources about 7 weeks prior to the attack from another place. He had gone back to that area for holiday. So one of the things we learned is that, especially our colleagues and collaborators, animal rescuers, the animals should be vaccinated. And the information from the Greek MIWA is that these vaccines are free. The vaccines they are free, and animals should be obtained from known sources. And virtually all of us here are Muslims, and we do know that we're allowed to keep dogs, but we're allowed to keep dogs with limitation. And this dog wasn't one of them, as in the hadith of the Prophet sallallahu alaihi wasallam, "Man iqtana kalban laysa bi kalbi الصيد ولا ماشية ولا الأرض يعني فإنه ينقص من أجره قيراتان كل يوم وفي رواية قيراتين يعني." And so this has effects on his spiritual health, as you might say, and also the malaika, the angels, don't enter the house where there are dogs. We are allowed to keep dogs for hunting. The Quran is very clear about that. Also to protect Mashia and Zira'a, to protect shepherd dogs, and to protect agriculture. Other than that, and also by extension, to things like guard dogs and dogs for detecting narcotics in the airports. But of great importance to the healthcare workers that may be here, the people in the ER should be aware of management guidelines. There were no excuse for not giving this gentleman rabies immunoglobulin. They were available. I have been opportune to be in the field once, and a gentleman was bitten by a fox that didn't attack him. He went to hunt the fox for no reason, just no reason, and he was bitten with puncture wounds on his left palm, and he presented immediately to the hospital. This is in another region. This is another region towards the border with Jordan, and he was not given again rabies immunoglobulin. Upon inquiry, the doctor said they didn't know they have to give him. So this is a really serious event, and these biologics are there. They're there. They've been provided for by the Ministry of Health, and they are there free of charge. And there is no reason why they should not be used, and they are there free of charge for anybody within the country. This has to be emphasized upon and should be requested. Now, like we lost diagnostics into Buraida, when we do not have diagnostics, what we would have, this is a graph from the WHO, website, observatory. We can see here that Saudi, we have a lot of cells with no data. And it's not impossible that the cells with data, that these are those data that are flowing. We said we don't do post-mortem testing. So we must know that in countries like the US, where they do have high index of suspicion for rabies, I mean, there have been studies that show that they've actually been able to confirm the person had rabies only after his death. And in Africa, we have seen, we have documented and published cases where people were mistaken to have cerebral malaria, and some of the people had their brain exhumed, and they were tested and found that they didn't die of cerebral malaria, they died of rabies. Again, another graph from WHO, we can see that Saudi Arabia is red, endemic, for human and also for dog rabies, and definitely for fox rabies. And if you see on the left bottom, it's stated that there we do not have data in terms of elimination. So this is a place we can focus on and work for improvement. Again, it's focused on here. This is very, very important. Later on, we'll probably talk about the National Transformation Program, where the National Transplantation Program, one of the themes is to encourage tourism. And countries normally would classify countries at high risk for rabies transmission when we don't have a nationally endorsed framework towards controlling and limiting rabies. That is, rabies is there in the animal found in the country, and very little is being done. The US CDC classifies Saudis as risk. Also, the PHE, and from what I do know,
excuse me, you have only 5 minutes left.
No problem, no problem.
Okay.
And so this is again showing that we do not have data. Like I was saying, the National Transformation Program, once we increase transform the healthcare, it will be available, so that the PHCs to those who are at risk. Those are at risk are those working on the farms, especially in places like Qasim and also Hufuf. And when to improve living standards, we really have to take care of the animals on the street in terms of stray cats. And we even foxes. We have foxes right now within big cities like Riyadh. We really have to take care of them. And number 8, in terms of the themes of the National Transmission Program, is tourism. And again, having rabies and not controlling rabies is something that puts the country on a high alert for rabies in travel advisories. And if we look at the US, they have a lot of imported cases of rabies from India. These are some of our collaboration we are doing with animal rescuers. There are a lot of them all over the country, and the National Transmission Program also calls for people volunteering. And this is one thing we're seeing much in the One Health area. We're collaborating with animal rescuers from all over the country. This is just one of them, Tabuk Pause. And we're also collaborating with universities. We did the first ever World Rabies Day event together with the King Faisal University last year. And we had on-spot vaccination of humans at risk, like veterinarians and veterinary students, and also companion animals. And this is a grab from the Tabuk Pause for this year's World Rabies Day. And this is one of the things they focus on. You can see these are stray cats that continue to reproduce in uncontrolled numbers on the street. And the rescuers themselves would be at risk if they get exposed to animals just like the one here, which is really, really sick. And is a grab. The gentleman actually touched this with his mere hands. It could have been scratched or licked by the animal. It doesn't need to attack for it to be rabid. And these are some of these rescuers. This is a graph from their sites. They are so committed to this work, but they also should know the risks which they can put themselves and others to. And so again, they are very active in getting animals vaccinated. I talked about this earlier on. And to cap, this is the final slide. I emphasize collaboration. This is a One Health must. We must collaborate all over. In our case, with the Baladia, with the Zira'a, we must collaborate with, as we have seen, with the universities and individuals who come together, like the animal rescuers here. And we see this picture is definitely from WHO. The emphasis is on canine, and as Charles reminded us in Saudi Arabia, our greatest problem will be the street cats and the foxes that might be. We do have stray dogs, but we have more stray cats, uncontrolled stray cats.
Sorry.
And so I'm amending. So it's to collaborate and very important to have laboratory access for diagnosis and to continue the advocacy. Thank you.
Thank you, Dr. Shams, for your interesting lecture. And now we will move to the last lecture with Dr. Muhammad Mubaarak. Dr. Muhammad Mubaarak will talk about the rabies epidemiology in Saudi Arabia. So, Dr. Muhammad?
Yes.
Yeah, you can start now.
Okay.
Hello?
Hello?
Muhammad, you can share the lecture?
Yes, I am doing.
Okay.
Just a minute, doctor. Just a minute, doctor.
Go to share screen.
Yes, I go there. Just a minute, doctor. So simple. Okay, just a minute.
Open the program.
حاصل ايش مشكلة ولا ايش؟
Open the program first, Zoom program, open it, and click on the share screen.
Already I did it يا دكتور لكن في شكل.
Did you open the lecture already?
Yes. Something is wrong. Share.
Or you can send it to Dr. Shams, maybe. And he can open from his laptop.
To share it?
Yeah, to Dr. Shams, maybe.
Dr. Shams.
Yeah, Dr. Shams.
Dr. Shams. Dr. Shams.
Hello, Dr. Shams. I think he's not connected.
Why not share يعني? Share screen.
Yeah, and then
screen here. Select Windows screen.
Select the same file. The file is already open, right?
Just a minute. والله مش عارف ليه هو كده. Already. Oh, طيب. Why? I have here open. الو
مرحبا دكتور، حياك الله.
الو
مرحبا دكتور، نسمعك واضح بس ما ادري الملف معك.
Yeah, Doctor.
أيوة.
Can you send the lecture to us, and we can open from my laptop?
طيب أنا أرسل لك يا عبد الرحمن.
Or to Abdurrahman.
Okay.
And you can start now until we can present the lecture.
Okay, just a minute. I send هذا دكتور دقيقة واحدة بس.
Okay, great.
already أرسلت هذا. أرسلت لك يا عبد الرحمن. عبد الرحمن. الو الو الو.
ايوه، هلو دكتور.
انا ارسلت على
Yeah, okay. He will present it. Can you start now until we can
General, first, thank you very much for our colleague in CDC Saudi Arabia for this organization, and thank you very much for Dr. Charles for details which we saw and listened minutes ago. And let me please to apologize for my colleagues who more than 140 doctors who request to enjoy our workshop, but unfortunately some technical problem not let him to enjoy. They are different from different levels of care, from primary health care, secondary, tertiary, and I apologize for him or them. Generally, why we talk about animal bites, or why we talk about rabies. Rabies is one of the serious diseases of zoonotic disease, which it's estimated as 6 of 10 non-infectious disease with the people. Zoonotic disease, and can be spread from animals, and it's 3 out of every 4 new or emerging infectious disease in the people come from animals. So why we talk about, because vertebrate disease and it's vital disease okay. In the world, epidemiological, this is global situation now, is global problem, health problem, neglected tropical disease affecting poor and vulnerable population. Geographic distribution, rabies has worldwide distributed with few exceptions, including Antarctica, New Zealand, Japan, Sweden, Norway, Spain, some Caribbean islands. Rabies is found through all United States of America except Hawaii. Hawaii, and more than 95% of human deaths occur in Asia and Africa. More reported in Asia. 20,000 persons die in India annually. This is about 36% of global deaths and 65% of the Asian human rabies deaths. 40% of people bitten by suspected rabid animals are children under 15 years of age. More than 15 million people require treatment and protection, which create financial loss. Human deaths from rabies, about 55,000 around the world. Situation in Saudi Arabia, Now let us talk about the reason, or by what or this talking about the reason by which it transmit, or the first type of transmission of rabies. These animal bites, which are a significant cause of morbidity and mortality worldwide. Dog bites account for tens millions of injuries annually. The highest risk is among the children, 15 years and under 15 years. Rabies is a significant health concern following dog bites, cat bites, and monkey bites. Saudi Arabia here is two more Asia. This graphic show here the distribution of animal bites, distribution according to each group and according to the a type of animals or kind of animals. This report animal bites up to June 2020, so a half of year only. 921 by person, people by dog, 536 cats, and 136. This is by mouse, and we have the others bites by dog, by cat, by monkey, by rat, by mouse, by camel, 44 cases by camel. If we look for the distribution of bites according to age, it's from 15 up to 44, up to 44 years, 1,137 persons or people bite by, and from 45 years and above or more, is it about 304. So in Saudi Arabia, why is this? Because maybe this the age of because a majority of these bites outside in the rural area, outside the city cases. We have here, this is a comparison between bites, general animals bites, and we have about the general animal bites and a number of dog bites compared with cases from 2014 up to 2020, June 2020. This 2014, the general bites, a number of bites reported 5,844 bites, animal bites. Of them, 3,044 by dogs, is more than 50%. No cases reported. 2015, there is 6,217 bites. Of them, 3,402 cases dogs bite. There was 3 cases of, unfortunately, 3 cases of rabies. In 2016, we have generally 4,479 bites, animal bites. Of them, 2,337 by dog. We have, unfortunately, was 2 cases. 2017, we have 4,079, of them 2,054 cases by dogs, and 1 case of rabies. 2018, we have 717 animal bites, of them 1,121 was not any case of rabies, no reported, no have. 2019 was 4,085, 4,805 bites, of them 2,581 dogs animal. We was 3 cases of rabies. Up to now, from January up to June 2020, we have 1,806 bites, of them 921 we having or was not any cases here. Hello? Hello?
Hello? Yeah, we can hear you. Your sound is clear.
Okay. We have human rabies from 2010 or 2011 up to now. Human rabies deaths relatively in Saudi Arabia, 50% due to animal bites by dogs, and others 50% due to organ transplantation. And for that, we have 9 cases. We have 9 cases at all from 2011 up to now. These 9 cases, 4 of them is due to organ transplantation. 2015, 2 cases. Unfortunately, 2019, we have 2 cases also. Other 5 cases, this due to animal bites or dogs bites. Of them, these 5 cases, of them 3 cases for foreigner person or people. Of them 2 who donors or donated to transplantation. Other one is the third one is came from Sri Lanka, also has a symptoms and signs here in Saudi Arabia. Bite in have a history of bites, dog bites. 3 deaths in 2019. Unfortunately, the time of develop symptoms and signs after transplantation not long time. Dog bites account for 1,000 of injuries annually. Highest risk among children this worldwide, but here in Saudi Arabia maybe less than 15 years. The second distributed kid. We have here برضو incidence of human rabies per 100,000 population, the cases. Okay. Generally, we has now, as Dr. Shams said, we have 9 cases up to now. These cases in Saudi Arabia due to rabies, due to dogs or bites in Saudi Arabia, we have just 2 cases. One of them, just two cases we have due to bites or And same time, we have 4 cases due to transplantation from donors, comes foreigner donors, has history of dog bites and dies with ETM. Generally, we can see it also in engagement of multiple sectors and one of health collaboration, including a community education and awareness programs and vaccination campaign are critical for this. And all we can talk about One Health, as said Dr. Shams and Dr. Charles, seriously. We need to be together to to maintain zero by 2030 as is a mission of WHO now. So 2030 is 0 case of rabies, inshallah. This briefly in Saudi Arabia, the epidemiological situation now in Saudi Arabia. Thank you.
Okay, thank you, Dr. Muhammad Mubaarak, for this interesting lecture. Now, we will move to the section for question and answer. The first question is where the local human transplant associated rabies cases reported yet in the scientific literature.
It's a question by Dr.
Yeah, by Dr. Charles.
Where is the local human transplant?
Yes, my question was the very interesting human transplant cases. Have those case reports been reported into the scientific literature yet? Over.
Dr. Shams or Dr. Muhammad, do you have any comment? Dr. Shams?
I think his microphone is muted right now.
Maybe. Okay, we will go to the another question. How can we prevent rabies? Do you think that killing the dogs are the best way for prevent the rabies? And how? What is the best method to deal with the dog that have rabies?
Yes, thank you. I'll try to answer that question first. As a means of control, neither OIE nor WHO recommends the routine killing of dogs as a means to control the disease. Why? Because it's never been shown to be effective in the long term. It has dangerous ecological consequences as far as bystander effects. It's very expensive, and there's significant ethical issues about killing healthy animals. In regards to the suspect dog, that's a very different situation. So typically, when there's a suspect rabid animal, when there are animal control officers, They're vaccinated and protected and specifically trained about how to safely capture, restrain, sedate, and euthanize a suspect animal so that the tissue may be submitted for diagnostic investigation. So there's a difference between not killing routine healthy dogs in the name of control as opposed to the proper either euthanasia, or if you don't have euthanasia, humanely killing the suspect animal. Sometimes that's done by gunshot, for example. If there's not an animal control officer or you can't sedate the animal with a dart, sometimes police officers who are specifically trained might shoot the animal in the heart, not in the head, so as not to damage the brain tissue. Over. Oops, sorry, I think you're muted.
Another, thank you, Dr. Charles, for your answer. Another question is there any studies that indicate that rabies can be transmitted from birds?
That's an excellent question. And as Dr. Shamsudeen mentioned, all warm-blooded animals are susceptible. And so that means that birds are susceptible. In fact, if we think about it, duck embryo cell vaccine was because avian cells are susceptible to rabies virus propagation in the laboratory to make vaccines. In the laboratory, you can show that birds are susceptible. And in fact, there have been cases reported in the literature. For example, one in India was reported in a chicken that was published in PLOS, Neglected Tropical Diseases. At least in this century, I think there's an issue because most people don't think about birds, most people think about mammals, that there are not widespread submissions because most people don't think about rabies in birds. And I'm unaware, at least in the 21st century, of any human rabies cases being reported by birds. There was at least one historical case reported, I believe it was a fox that exposed a goose. I think the goose developed rabies, and supposedly in Europe, the goose bit the farmer and the farmer died of rabies. The problem is it was never diagnosed. It was never properly investigated. It could have been that the farmer was bitten by a dog or a fox. So at least it's possible. We recognize that birds don't have teeth, and so the possibility for transmission is small. It's always possible, for example, if there was a vulture or a raptor, like a hawk, if that bird was infected and it happened to contaminate its claws or its beak, since both the claws and beak are very sharp, it's at least possible that it could contaminate someone. It's just there have been no modern documentation of human cases, even though birds are susceptible and have been reported. Over.
Okay, thank you, Dr. Charles, for your clear answer. I think now we reached to the end of this webinar. I would like to thank all the
Dr. Ezzuddin, excuse me. This
yeah.
question by Dr. Charles, where the local human transplant associated rabies cases reported, yet
Yeah.
it's various cases in United States, yeah, in Maryland, 2013. And
Yes, we've had multiple episodes from corneas and organs and other tissues
yes,
in the United States. My question had to do with the local report in Saudi Arabia that both you and Dr. Sham reported. Is that going to be reported in the peer-reviewed literature? The transplant cases from Saudi Arabia.
yes, we have 4 now cases, and maybe this by the last 8 months we have formed here a big committee to take up and all the regulars of transplantation, and also this developed many questions. Already we surveilled it, and done, or we had good outcome from this committee regarding to transplantation, and also maybe this will be very concern or under people or donors from Asia, from India, from Sri Lanka, from Nepal, because this case is all from there, and the bitter of animal bites, they are very high. I don't know. This is a.
Yes. Do you plan to write up those case reports so that others can find out about this very interesting situation and learn from your experience? Are you or someone else from the ministry going to write those up into the scientific literature? Over.
Yes, inshallah. Yes, inshallah.
Excellent. Thank you.
Thank you, Dr. Muhammad, Dr. Charles, for your clarification for this question. The last question is for Dr. Charles. What is the maximum incubation period for rabies disease?
Thank you. We're really talking about the biology of rare events. Most of them, of course, are between 1 and 3 months. With very, very severe bites, they can be short. For example, if a wolf were to attack a villager or a child, the child can be dead in 10 days. Those are the shortest that we know about, a week to 10 days. The longest are hard to do because if you think about it, that means somebody could have been bitten as a child and then become an adolescent, or bitten as an adolescent and then become an adult and forget about it. And most times postmortems, necropsies are not done. In the United States, they've been decreasing. So if someone dies traumatically, hit by car, falls down the steps, or suffers cardiac arrest, they're not going to undergo a necropsy. So we may be missing long incubation periods. As many as 10%, maybe more than 6 months, and as maybe as more than 1%, maybe 1 year. The longest documented, and when I say documented, I don't mean stories, because there's lots of stories our colleagues tell us. So for example, there's a story of a 19-year incubation period in India. The problem is, in a hyper-endemic country like India, you could have been bitten or scratched or licked last month and not remember it, but you do remember that very traumatic dog bite that you didn't receive prophylaxis 19 years ago. So it was never thoroughly investigated to look for alternate explanations. The longest documented properly investigated incubation period we have for human rabies was 8 years, which is obviously way over on 2 or 3 standard deviations beyond the average. Very rare, very unusual, and we don't understand it. It means, was the virus in the central nervous system or not? Was it in the nervous system or not? If it wasn't in the nervous system, what organ or tissue was it in? Was it just a few virions? Was there some event that then caused the virus to replicate again? Did the patient become immunocompromised? We have no models nor explanations based on our understanding of pathogenesis to explain very, very long incubation periods. And it creates a dilemma when a patient reports to a physician and says, not that I was bitten last week or yesterday, but rather I was bitten a year ago. This creates very great problems for us in the US when we had our first military member die from Afghanistan, because when the US military did their review from many of the troops that were coming off of service, how far back do you go and offer prophylaxis? If they're physically healthy and you have hundreds of soldiers that may have been bitten more than a year ago, it creates not only a public health, but a financial dilemma when you start thinking about long incubation periods and the very effective human prophylaxis. Thanks for that very interesting question. Over.
Thank you, Dr. Charles.
I have just a question, please, Dr. Charles, if please.
Yeah.
Hello,
Yes,
Dr.
sir.
Charles.
Yeah, just unmute your mic. Yeah, okay. Okay, we can hear you.
I am asking about regimen. What's the difference between three regimen? How every or each country use depends on what yeah, depends on what each country use regimen. Now we have 3 regime. WHO is put 3 regime.
Yes, usually a country will look at the evidence and make the decision for themselves as to what regimen to use. So, for example, as was mentioned about the high burden in Asia, I've been to some clinics where one hospital sees 500 to 600 patients a day. Obviously, in a place like that, they're going to move to a dose sparing regimen over 1 week because it's less expensive and it allows them to meet many patients. If you have another country where in the entire country you only see a few hundred patients with animal bites over the course of a given year and money is not an issue, then they can go ahead and not use a dose sparing regimen because it wouldn't make any sense, because they wouldn't be seeing in one facility more than one patient a day. So very short dose sparing intradermal are used for very high volume bite clinics, but at a minimum, when you go ahead and look at the evidence immunologically and epidemiologically, based upon what the material from the producers has, and your regulatory authority helps to review that, there's no reason based on the evidence that you need more than 4 doses of vaccine on days 0, 3, 7, and 14 at a maximum, just based on the medical evidence. And that's the thing that the SAGE and the 2018 WHO recommendations tried to emphasize. But it's really up to the country and the regulator. Every country decides based upon their own internal review of the evidence. Thank you. Over.
Thank you very much.
Yeah, Dr. Ezzuddin, could I just add to that?
Yeah, you can talk to
Yeah. Okay. Charles asked a question in the chat and asked about why we use rodent where we do test, we do give people with rodents PEP. This is a question that I've also asked. And the question now is, how do we get out of it? Because I don't think it is economically viable. I don't think there is evidence for us to continue it. And I think if there's a way, we can just start the process to try to stop this, it will save a lot of vaccines and a lot of stress. Plus, like I just put there, we even had the case where we had to give somebody, according to the literature, we gave somebody vaccine based on an ostrich bite, ostrich Naam. This ostrich was bitten by a fox, even though the fox was never tested. That's the first thing. The second thing is, yes, I would really like us to go down to a 4-dose regimen, because even though everything is free, we do get situations where more often than not, maybe only 40% or 50% will complete the 5-dose. And so it's more like a wasted thing. And then we really don't also test whether the animal was really positive. We just continue. It's just like just blind therapy. So what would you suggest? Which way would you suggest to go out of this? Because now we have to do things and justify it in terms of economic input. Thank you. Over to Charles.
Okay, thank you, Dr. Shams. I have another interesting question. For the countries that have that is endemic in rabies disease, do you recommend to include rabies vaccination in the routine vaccine schedule?
Thank you.
For, yeah, you can.
WHO has looked at this issue, and except for occupational exposures, such as we mentioned, laboratory diagnosticians, veterinarians, veterinary staff, wildlife workers, people who work, animal control officers, definitely everyone who is at risk of occupational exposure should have pre-exposure vaccination. However, when they've looked at other populations, for example, children, they've not found any common situation where the incidence of exposure is high enough. And in fact, you'd be doing it forever. So it's not cost effective. Rather, they think that by doing laboratory-based diagnostics, risk assessment, post-exposure prophylaxis, and routine mass vaccination of dogs, that would be able to prevent the problem long-term. The only place that pre-exposure vaccination is soundly supported in very rare situations would be places in the Amazon. And in Amazonia, there are indigenous peoples as well as other communities that are routinely bitten by vampire bats. And because these are very difficult to reach place, that by the time the country is alerted, the Ministry of Health, the outbreak has ended and you have dead children. Those are probably the only places, because you're not routinely controlling or vaccinating vampire bats. It's not like dog situation. You can't predict where it's going to happen. You can't do anything with vampires yet. About the only strong justification for pre-exposure vaccination for childhood might be in parts of Amazonia in South America. Nowhere else yet have people found a high enough incidence to justify it economically. Over.
Yeah, thank you, Dr. Charles. I think the cost effective is a very important issue to consider the rabies vaccine as a routine for children. Another question, what is the role of GAVI, rabies vaccine production and distribution? I think this is an organization or something.
Yeah, Gavi is an organization for vaccines. I'm sure Charles can answer that.
Yes, thank you. In fact, we were hoping this year that Gavi would have engaged. Over the past 10 years, rabies was being considered for Gavi support in very low income countries. The first year, we lost out to a few other neglected tropical diseases. The next year series was during the economic downturn. And so Gavi was supposed to be involved already by 2020, when you know what happened. We had the global pandemic with COVID. So we're very hopeful that next year Gavi will be able to help support in those poorest countries the availability of human rabies prophylaxis. And we hope with this aid through Gavi in acquiring inexpensive vaccines, that those countries will then be able to focus with their own economic money the mass vaccination of dogs. So you'll have concomitant in-country resources going for focused on mass dog vaccination, with some Gavi support to acquire and use human vaccines in post-exposure prophylaxis. Over.
Yeah, Charles, will Gavi support support RIG as well, or just the vaccines?
That's another excellent question. We wish that Gavi would support vaccine and RIG, and we hope that if there are global opinion makers or people who can influence positively Gavi, that they would actually do that. Unfortunately, it looks like they may only support vaccine. And of course, if we use dose sparing regimens like intradermal 1 week, we know that most of the cost of prophylaxis is due to the RIG. So we're in a little bit of a conundrum that we're very happy for Gavi support finally. We hope that that'll allow more people, particularly children, to be protected. The dilemma becomes, how do we go ahead and get further support for RIG? Gavi will probably only support vaccines just historically. They don't support immune globulins, but it's not based on evidence. It's not based on science. It's not based on public health. It's just based on precedence. So if you know any influential global opinion makers who could influence, Gavi will support both RIG, will save more children in the long term. Over.
Thank you, Doctor. Another important question. Is there any treatment, or is there any like a trial to make a treatment for rabies? What we know that rabies is very fatal, and I think 100% the death rate, I think the case fatality is 100%. So is there any treatment trial or is going on, or do you have any idea about that?
Yes, that's a very good and difficult question, because as all of us interested in public health, we're on the horns of a dilemma in that we're about prevention. So we're talking about mass dog vaccination. We're talking about post-exposure prophylaxis. We're talking about health education to prevent exposures. We're trying to support pre-exposure for those occupationally at risk. So whenever we have a human case, that means we've failed in all of those things. And that's where most of the energy and most of the costs need to be for the long term. But at the same time, you know, it's a very difficult question when the phone rings and it's a parent and their child has all the clinical signs of rabies, what to do. By the time that we first realize that that patient may have rabies based on history and signs, and you have the infrastructure to confirm it, because you're going to have to follow that patient, as we did with Gina Giese, over weeks. it becomes a very exhausting and expensive undertaking. And so instead, most of the global community is saying, one, we need a better model to understand the pathobiology of rabies. Two, we need to have a practical animal model that we can use some of our tools based upon our understanding of the pathogenesis. And three, we hope that from some of the antiviral drugs that we're getting for other diseases because of human communicability, whether they be the filoviruses, the hemorrhagic fevers, or because of SARS and MERS, or because of coronavirus, will probably, because of the conservation of some of those viral genes and proteins, will probably ride on the coattails of other drugs from other diseases, because that's where the monies are because of human communicability, because rabies is not communicable as opposed to infectious, that will probably get some better tools as far as drugs. The animal models will teach us which way to go. They'll be much less expensive. And in fact, one of the things the veterinary profession should think about is based on what we know about rabies now and what we know about good medical care and all the things that can go wrong and the poor tools that we do have. Why the veterinary profession, provided that you've got the time, talent, and treasure, meaning you've got the staff and the space and the wherewithal, there is no reason that the proper veterinary facilities who are trained and are vaccinated should not be thinking about routinely trying to intervene safely when you have a clinical case of rabies in a domestic animal. Because, you know, a dead camel is different than having a dead child if you fail. So I task the veterinary profession to use all of its energies based on what we know now to redefine it and to utilize what we would gain from it for the treatment of human rabies. There'll never be a trial per se because it's a rare disease, it's a neglected disease. It's not like our very common human diseases, it's a zoonotic disease. We also have to understand that by the time the phone rings, even with the best minds and the best tools and all the money, because it's going to be hundreds of thousands of dollars, that we still have a high rate of failure. And so prevention is the key. High failure rate is going to be an issue because you'll have a fulminant encephalomyelitis by then. You'll have healthcare staff that'll be afraid to treat that patient. And lastly, even if the patient survives, there's a high probability of sequelae. So Gina Giese, even though we never thought a rabies patient would go to college and get married and have children, which she did, which is remarkable when we think about this disease and shows you what we can do, even Gina Giese still has sequelae. And unfortunately, some of our most severely affected patients have later died because of those sequelae, and some of them may need lifelong rehabilitation. So I'm cautiously optimistic that we may, in the years to come, have a better conversation. But right now, I think our primary focus needs to be about prevention. Over.
Yeah, Charles, before we end, let's go practical right now. You mentioned DRIT in one of your slides. Could you just shed more light on how it can help us decentralize rabies diagnostics, human and animal, and how effective it is in terms of cost effectiveness?
Sure. The DRIT is very sensitive and specific. It's recognized by both OIE and WHO. It's less expensive than DFA because you don't need a fluorescent microscope. So it's rapid, sensitive, specific, inexpensive. You either need to make your own conjugate, which the techniques and how to make any rabies diagnostic conjugate are in the WHO laboratory techniques book, or you need to buy it from someone. People all around the world, from Europe, Australia, North America, the Philippines, India, are making, South Africa, are making their own conjugate, or collaborate with someone to help you make it. So buy it, make it yourself, collaborate with others, and that will allow anybody who knows how to use a microscope to be able to use the DRIT, or for surveillance purposes, decentralized, to go ahead and look at some of the references that I supplied on the linear flow assay. And as long as it's used for surveillance, not for making public health decisions for prophylaxis, some of the linear flow assays are producing some very good results for decentralized surveillance. Thank you for the question.
Yeah, so will you compare, how do you compare DRIT with PCR?
Well, DRIT is looking at antigens in about an hour using a light microscope, as opposed to the very highly sensitive and specific real-time PCR, but which you don't want to go ahead and cross-contaminate, and is not going to be easy to do in the field. What you can do in the field is collect brain tissue on filter paper and then send it to a centralized facility. So your surveillance is decentralized, but your diagnosis is centralized, as opposed to the linear flow assay or DRITs. Both your surveillance and your diagnostics can be done locally. And so, for example, we train not physicians or laboratory technicians, but rather we train biologists in North America, such as in Canada or USDA, to go ahead and collect the animals in the field and do the DRIT tests themselves, or they could do a linear flow assay. It's really up to each country to decide purpose-driven diagnostics and what from the regulatory environment is the best circumstance for you to apply. Thanks for the question. Over.
Thank you.
Any more question?
Lamia is having a question there. This is from Lamia.
Another question from Lamia. She said, is there any screening test for rabies among animals?
It's a very good question in terms of screening. Serology is overlooked in animals, and so there are situations where animals are reservoirs, not vectors, but reservoirs, where you can do serological studies to get an indication of which species might be infected. And so, for example, when people are doing surveillance looking for bat lissaviruses, they need to look for the right virus. And so that's one of the reasons why I showed that slide of the kinds of bat species and the lissaviruses they'd be associated with. If you use rabies virus in that serology, they're all going to be negative because there is no rabies virus in bats in the old world. So serology is something that can be looked at. As far as keeping the animal alive, there's no diagnostic test that will get you an answer any faster than a postmortem. And if the animal has an encephalitis, from a veterinary perspective, the only humane thing to do in an animal with encephalitis is to euthanize it, particularly if it's not a rabies suspect. The only thing that you should do if it's involved in exposure situation is euthanasia or humane killing. So serology is usually used for wildlife surveillance, just to ask, is the presence or absence of that particular virus in that population circulating? And then once you find out that it is or isn't, you can focus on that species and that virus for some determined surveillance in sick animals. But otherwise, looking at nuchal skin or muzzle biopsies, they don't give you an answer any faster than what a DFA or a DRIT or a real-time PCR test would give you. Over.
I think one of the things in terms of animals is there was a recent, very recent MMWR from the US CDC about 25 or 26 dogs that were imported into the US. And I'm sure Charles have read, you must have read about it. And though they had certificates that they had rabies vaccine, it turned out that one of the dogs was actually incubating rabies, and they had to test the other. Charles, did you know about that study?
Yes, of course. And we've always been involved in this kind of problem with importation of animals. And ideally, if the animal's given routine health care and has really been vaccinated and has a bona fide health certificate by international regulations, there should be no problem. The issue becomes when people cheat. This is an issue whether we have falsification of documents or veterinarians who don't exist, or even the heretical problem with counterfeit human vaccines that we've heard about in Asia in particular. So this begs the question that if people are going to go ahead and have counterfeit human vaccines, you know that they're always going to go ahead and have counterfeit and falsification of documentation, and the animals suffer, the people who are exposed become the patients with the health economics and the fallout. What we do for animals for importation globally is that serologically we look for virus neutralizing antibodies. And so there is a pet passport that can be done and is supposed to be done for verification of vaccination status before the animal gets exported. That verifies that that serum that came from that particular animal, and if in fact they're seronegative or they have inadequate virus neutralizing antibodies, they can always be boosted and another sample sent for serological analysis before importation, rather than have these animals show up on your doorstep and create problems for everybody. We have to recognize that North America is now a canine rabies-free continent. And by having improperly vaccinated or falsified health certificates or rabid dogs that could be let loose in the community, we could lose our status as a continent. So this is a very big problem that creates problems for everybody. Thank you. Over.
Yeah, thanks.
I think that was the last question. I apologize for not able to answer all the questions. We choose only the most important question. And at the end, we would like to thank our speaker, Dr. Charles and Dr. Muhammad Mubaarak and Dr. Shamsudeen. And I would like to thank you all for your attendance. At the end, I would like to remind you to fill out the questionnaire to get the certificate of the webinar. I hope that all of you get benefited from this webinar, and we hope to see you soon in another
Thank you. Bye-bye.
Thank you all. I appreciate it.